All check mic testing 1 2 check.
भाई सही है ना?
All check mic testing 1 2 check 1. All check mic testing 1 2.
Rakhi. Yes, sir. Good. Good morning, everyone. Today I am presenting my thesis topic, which was a randomized comparison of flexible endoscopic polydocanol liquid and foam sclerotherapy in cirrhotic patients with bleeding from internal hemorrhoids. My guide was Dr. Vikram Bhatia, sir. So first background, the existing literature of flexible endoscopic liquid sclerotherapy of internal hemorrhoids. Most of the existing studies have used only proctoscopic injection techniques. Only 5 studies till date have used endoscopic sclerotherapy techniques for hemorrhoids. All these 5 studies had variable protocols and variable sclerosant. There was no continuity in these protocols or the use of different types of sclerosants. Whether in case of foam sclerotherapy treatment, 6 recent prospective studies showed good efficacy and safety, and there was some evidence of safety with bleeding disorders and antithrombotic use. And it can be said that it may be more safe and effective than liquid polydocanol sclerotherapy and rubber bed ligation. But no studies till now have used flexible endoscopic injection of foam sclerotherapy for the same use of internal hemorrhoids bleeding. In this slide, I have listed 3 studies, but as you can see, the first study, the surgical hemorrhoidoplegy, the study which showed that it was although feasible and safe, but the applicability on the patients of cirrhosis is questionable. Second studies compared EBL, which is endoscopic rubber band ligation, versus stabled hemorrhoidoplexy, which was a RCT with 26 patients, and the third study used endoscopic band ligation versus the endoscopic sclerotherapy. But this study has multiple methodological flaws, including the use of glue injection in the sclerotherapy arm. So lacuna is the efficacy in cirrhosis, efficacy and safety of sclerotherapy for treating bleeding hemorrhoids and all those. So these are the current recommendation of international guidelines on the treatment of internal hemorrhoids in patients with cirrhosis. Out of these, only two addresses portal hypertension. The one guideline says that conservative approach to be tried first, differentiate rectal varices and conflicting reports on rubber band ligation. The second guideline, Belgium guideline, said to use rubber band ligation in child A and it should be avoided in child B and C. No consensus. So the current lacuna in literature is the efficacy and safety of endoscopic cell therapy for treating bleeding hemorrhoids in patients with cirrhosis is not known. Our hypothesis was that polidocanol foam sclerotherapy is more effective than our institutional practice of liquid polidocanol sclerotherapy for bleeding cessation from internal hemorrhoids in patients with cirrhosis. This was an open label parallel group randomized control study. Our aim was to compare flexible endoscopic polidocanol is liquid and foam sclerotherapy in patients with cirrhosis with bleeding from internal hemorrhoids. Our study population was to be patients with cirrhosis attending outpatient clinic or admitted with anorectal bleeding suspicious to be hemorrhoidal in origin. It was a single center study. Duration was November 2023 to July 2025. Primary outcome was complete cessation of hemorrhoidal bleeding episodes at 1 week after endotherapy. These were the secondary outcomes, which were defined by different scores, which were calculated in the mean follow-up period of our study. Sample size estimation, a sample size of 60 with 30 in each arm was decided after including the 10% dropouts. Patient randomization was done by in-house IWR system, which is ILBS web-based randomization method developed by Department of Clinical Research. These were the patient evaluation tools, which was Gallagher grading for hemorrhoids, Sky-Mundo bleeding score, hemorrhoidal disease symptom score, VAS score for post-procedure pain, and 4-point scale of satisfaction. There were 4 follow-up timeline: baseline, 1 week, 4 week, and 8 weeks. Inclusion criteria was any cirrhosis patient came with anorectal bleeding either ongoing or within last 1 week, just to be hemorrhoidal in origin based on clinical features and endoscopic evaluation. These were the exclusion criteria. The most important one was coagulopathy with a INR threshold of 2 and platelet of 50,000. Trial interventions we divided the patients in 2 arms, group 1 and group 2. Group 1 received sclerotherapy with 1.5% liquid polidocanol. Group 2 was received foam sclerotherapy.
Rajat, go slow here and explain protocol carefully.
Yes. So our protocol was gap assisted flexible endoscopic treatment in both the groups. Basically, we used a distal short straight cap as an extension of the while doing sigmoidoscopy by upper GI endoscope, which basically it helps in preventing air leakage during insufflation and improving. It also improves endoscopic exposure. Basically, it converts a flexible endoscope into a rigid anoscope, which is used by surgeons to treat internal hemorrhoids. So in group 1, we gave sclerotherapy with 1.5% polidocanol. Normally, polidocanol is a detergent sclerosant which comes in 3% dilution in company via company to our endoscopic clinic, but we dilute it with distilled water and make it 1.5% because 3% can cause ulcers when treated in patients with cirrhosis. The group 2 received foam sclerotherapy. Foam was made by using Tessari's technique. Basically 1 part polidocanol and 4 part air, and by using a 3-way and 2 needles, just like we use agitated saline in doing a saline contrast. Sclerotherapy of hemorrhoids. Basically, these are the equipment. We used a 23 gauge 5 millimeter long V-ejector sclerotherapy needle for injecting sclerotherapy. This is the polidocanol available at our center, and it is diluted by mixing in distilled water. So basically, how do we inject? We inject by using a technique called Blanchard technique. Basically, sclerosant is injected in some mucosa at cephalad portion of each column. The injection location is in transitional zone or columnar mucosa of upper half of anal canal above the dentate line, because below that it can be painful, and it is believed that below the dentate line external hemorrhoids are found. They are not internal hemorrhoids. Or candidate columns injected, all columns were injected in one session, and the injection site before injecting was brought to lower half of endoscopic view by scope rotation. Subsequent injection by clockwise scope rotation by using our in-house LPRA protocol, which is left, posterior, right, and then anterior, doing clockwise rotation. So this was this is Tessari's method. We use 1 part liquid sclerosant with 4 parts of air, 1+4, and we mix it basically by using a stop syringe and a 3-way cannula, and we connect it directly to the V-jector 23 gauge syringe before giving foam sclerotherapy. This is the endoscopic image by using the distal cap in the upper GI, the gastroscope, and we used to do sigmoidoscopy by using the short distal straight cap as an attachment. The cap is transparent. These are few pics of internal hemorrhoids as it was seen in our patients. This is the sclerotherapy needles, and this is the sclerotherapy we are doing. We are injecting the hemorrhoid columns. And we used to do 1 column at a time, and in the clockwise rotation. This is a video of us injecting sclerotherapy. It is liquid sclerotherapy we are doing in a patient. This is another video. Most of the times at the puncture area, the few bleeding was found, but it was controlled by giving gentle tamponade by using the scope, and after pulling out the scope, we used to give finger massage also in these columns to control the bleeding. So this was our post case. Case is basically cap assisted endoscopic sclerotherapy. This is the post case management of our patients. We used to give according to this protocol. This is the patient follow up results. So this is my study flow consort diagram. We screened total of 180 patients, portal hypertensive patient with an rectal bleeding. Only 25 patients we were able to randomize because of our inclusion criteria and high exclusion rate. Most of the exclusion were due to non-hemorrhageal source of bleeding. Most common was anal fissure. Not meeting inclusion criteria, declined to participate, and failure to randomize were 20. And they were followed till 8 weeks. So these were the baseline characteristics of the whole cohort. A majority population were male, 86%. The mean age was 48.8 with the standard deviation of 12.3. Mean bilirubin was 5.3. INR and platelet were 1.7 with a standard deviation of 0.5 with a platelet of 100. Mean platelet of 100 with standard deviation of 62.6. We also have a look at the CT images of 131 patients out of total cohort of 131. Which showed splanchnic venous thrombus in 15% of them, pararectal collaterals in 63 patients with 48% of them, and upper abdomen shunts in 46.6% of them. This was the etiological spectrum of anorectal bleeding presented to ILBS in the study duration of 1.5 years. The majority of them were due to internal hemorrhoids, which is 57%. Followed by anal fissures, 12%, followed by rectal varices, 6%, followed by other causes like proctitis, telangiectasias, and in 18% of more patients, no cause were found. And while talking about syndromic diagnosis, decompensated cirrhosis comprise the most largest group of 72%, followed by compensated cirrhosis, then ACLF type A according to Kyoto consensus, and NCPH of 4%. This was the etiological wise classification with the majority of 46% of them having alcohol associated liver disease, followed by metabolic associated steatotic liver disease as the second most common cause, second followed by hepatitis B and C. So these were the severity parameters. Basically, 61.6% presented with hemoglobin drop, and out of which, out of the total cohort, 20.6% presented with hemodynamic compromise. Basically, it shows that the patients with anorectal bleed, which is often classified as, which is often ignored, is also an important point of hemodynamic compromise in patients of cirrhosis. Hemodynamic compromise was defined as more than a need for vasopressor to keep MAP of more than equal to 65. And in this graph, we are showing the transfusion burden of these patients. Basically, there was a huge range of 0 to 26 of PRBC units, but a mean of 3.3 with high standard deviation. That's why we used mean, a range of 0 to 26. It showed that anorectal bleed patients also require a high number of coagulation corrections and the blood product transfusions. So out of the randomized patients, internal hemorrhageal bleeding, our median age was 49 with range from 37 to 71, which was comparable in both arms. MELD was 15.4. The MED was at a lower side because we took our inclusion criteria was INR and platelet, which was the baseline characteristics were comparable in both the arms. This was the syndromic diagnosis majority as compared with cohort. The majority was same, decompensated cirrhosis, out of which alcohol association was the most common. This were the radiological finding and history. Out of total cohort, 20% of them has prior history of hemorrhageal surgery. IMV diameters and common iliac vein, internal iliac vein diameters were checked in both the groups, which were non-significant, and it were within the normal range of 3 to 6 millimeters, especially inferior mesenteric vein. And rectal wall thickness was also measured, which was also comparable between both the arms. Sir, yes, sir. So, uh, ma'am, bleeding cessation at 7 days. Yes, ma'am. The p-value was no statistical difference in both the arms in liquid sclerotherapy or foam sclerotherapy. Both were comparable, and total overall 88% of them had controlled bleeding at 7 days. These were the secondary outcomes of bleeding cessation of the same continued patient at 4 weeks and 8 weeks. They were also non-significant in both the arms, and need for second endoscopic cell therapy or transfusion requirement, although non-significant, but they were in numerically favor of liquid group. Yes, ma'am, 25 patients, 12 in foam group and 13 in liquid group. Yes, ma'am, it was.
So the sample size was 60, but the recruitment was prospective, but we found only 20. So 180 procedures were done, sigmoidoscopy for anorectal bleed, but only 25 fulfilled the inclusion criteria. Our inclusion, since it was an initial study, our inclusion criteria was very tight. And by the time practically the student starts, half the time is gone. So the student had to submit after 25 patients were actually included. But we did sigmoidoscopies at 180 patients. So we found only 25. So our sample size is definitely not reached. Sample size was 60. It's an underpowered study. So hence the data should be taken as hypothesis generating and exploratory.
So these by way primary and secondary outcomes, which were non-significant but numerically in favor of the liquid group. Uh, all the hemorrhoidal disease severity scores were calculated and they improved in both the groups. Again, no statistically difference was found in both the groups. Safety profile, no procedure related.
But sorry, I'll interrupt you here. So go back. No statistically significant difference was found here, but since, as you rightfully said, the sample size was 60 and we randomized only 25 at the end of it, we may be looking at a type 2 error because the study was underpowered to detect a true difference between the two arms. So the result should be taken as that overall in hemorrhoids, if you do sclerotherapy, either liquid or foam, it is effective in close to 90%. And it's a good modality in patients of cirrhosis who do not have coagulopathy. So that's the only but very important conclusion that we can draw from this study.
Basically, ma'am, these are three graphs. The first one is Gallagher grading improvement over time in our patients in both the groups, Group A and Group B. Group 1 was basically foam sclerotherapy and this liquid sclerotherapy. This is the HDSS score, hemorrhoidal disease symptom score. This is the 5-point score calculated at baseline and every time frame of our follow-up till 8 weeks. It also showed improvement in both the groups. And this is the Guymondo score. This is also a internationally accepted score for hemorrhoidal bleeding score, and it also improved in both the groups. Although, as sir said, there was no statistical difference in both the arms, but it showed that in cirrhosis patient, the use of endoscopic sclerotherapy in any way is a good alternative to prevent them from to treat their anorectal bleeding. Safety profile also wise, we found no procedure related serious adverse events in either group. No ulcers, perforation, or severe sepsis we found in our randomized group directly, which were or directly attributable to the procedure. We found only mild perineal pain, non-specific discomfort, and in one patient we found urinary retention, which was present pre-procedure also. This is a GE model with repeated measures employed to assess the longitudinal trend of hemoglobin. Basically, at the baseline, the hemoglobin was low in these patients when they came here, when they presented to us, and we performed sclerotherapy. Basically, this chart shows that over a period of time, the hemoglobin stabilizes and it improves the hemoglobin. Further, concreting our claim of controlling anorectal bleed in these patients by using endoscopic sclerotherapy. Basically, the past study showed that foam sclerotherapy was superior. So we cannot say that because the sample size was very low, but we found that liquid sclerotherapy is more showing numerically more slightly better as compared to foam sclerotherapy. Uh,
So the sample size was calculated as per the efficacy of treatment, but there is no data of the prevalence of internal hemorrhoids. So it's very strange, but if you have 100 cirrhotics, as of the knowledge which stands today, we do not know how many are going to have internal hemorrhoids. Very interestingly, on flexible endoscopy, there is actually no definition of what is engorged anorectal columns and when you start calling them internal hemorrhoids.
Can I request the student to
Sorry, the question was directed to Ms. Rajat, you answer, please.
Ma'am, as sir said, there is no clear differentiation between what is a rectal varix and what is a internal hemorrhoid. And there is no defined data in this.
I'm sorry, I did not say that. We very clearly distinguish between internal hemorrhoids and rectal varices.
This prevalence. There is no studies on, there are no literature existing on prevalence of internal hemorrhoids as a origin of anorectal bleeding in this patient population of cirrhosis. So
I don't agree with that. There's huge data from 1980 on the prevalence of bleeding from anorectal varices vis-a-vis hemorrhoids. It's a Hoskins paper, landmark paper, 1980.
So again, sorry, I'll pitch in to clarify. There is a prevalence data of rectal varices in cirrhosis and EHPV, non-cirrhotic portal hypertension. There are a huge number of studies, close to 20. I recently tabulated with a very wide variation between different observations. So we have some prevalence data with huge variations of in the prevalence of rectal
No, it's not
varices.
prevalent, it's just the bleeding part. So there is
Hanji.
history of blood loss from hemorrhoids separately documented.
So rectal varices का सर डेटा है, internal hemorrhoids का डेटा जहाँ तक है, that is surprisingly lacking. So previously people have called them anorectal varices, overlapping. So we have good amount of data for rectal varices. Internal hemorrhoids, I think we lack quite a lot.
Anyway, let him conclude.
So I will conclude by saying that both foam and liquid polidocanol sclerotherapy demonstrate comparable efficacy and safety for managing bleeding internal hemorrhoids in patients with cirrhosis. However, liquid therapy in this small study showed a trend towards better immediate control and lower transfusion requirements, making it a robust choice in this specific population of portal hypertension. Our limitation remains small sample size, short follow-up period, and single operator use.
So, hold on. Any comments from the guide?
So
The limitations.
well, the limitation was the sample size. That was the only limitation as to me. So I did all these endoscopies. So I did 180 sigmoidoscopies in patients who had anorectal bleed, which was bright red bleed per rectum. So we showed that this is hemodynamically significant in close to 1/5 of these cirrhotic patients require transfusion. But the unfortunate part was the inclusion of hemorrhoids was only applicable hemorrhoids was only 25 patients out of these 180. So we did not achieve the sample size, which should have been 60. So the study remains underpowered. So out of a sample size of 60, we randomized only 25.
Sir, what is the protocol? All patients has been treated or some has been just observed? And what are the criteria to take a decision for treating them?
No, so point is the patient has come to us with bleeding. So these 180 patients in whom I did sigmoidoscopy, we treated everybody who required treatment regardless of hemorrhoids or not. So if they had rectal varices, I treated them as rectal varices. But the thesis was on internal hemorrhoids. So that
So
data
that's simply because internal hemorrhoids in a cirrhotic, we prefer not to give any intervention in few cases. So what is the protocol here we have followed so that we can adopt in a regular?
So
Suppose-
these were active internal hemorrhoidal bleeding in cirrhotic patients, and we treat them. So if a cirrhotic is bleeding from internal hemorrhoids, if there is no coagulopathy cutoff, which was arbitrary, but we defined it, then we treat these patients for internal hemorrhoids because they keep on bleeding. And I personally would definitely treat
Sir, I
these.
think we have seen maybe around 20-30% patients who internally hemorrhoid bleed, they are admitted symptomatically. They're not needed any endotherapy. So I don't think that every patient who comes with a hemorrhoidal bleed in the cirrhotic, we treat them all with endotherapy.
No, I think any patient of cirrhotic.
Right now, we limit to the thesis part and not to the other discussion. That would be better. You should follow up. This is a very important area, Sajit, and I think very carefully analyzed. You should complete the sample size, and I am surprised that you submitted with a smaller sample size. We didn't know that. In future, I think all theses must go through a process that if the sample size and others are not completed, they are withheld. I mean, not for you only, for everyone. Coming back to the, can you go to your stats table? You are showing a trend. What is the trend like? Go back. How is it? Liquid is better than foam. What is the p-value? Where is the p-value? That liquid is better.
So statistically, there was no difference.
No, show me the actual. What is the p-value?
Previous slide.
So there is hardly any difference 92% and maybe some 80% or so. So I would not even say that there is a trend. For trend, you are 0.06 or 0.07 or 0.08. It's not there. I would say they are saying. I don't know what the others' opinion is, but I feel they are the same.
No, we found no difference, and then
Yeah.
we, as of now, should take it as the foams is so much cumbersome to prepare
Yeah.
that today, if I have to go forward, I'll just use the
But then we
standard
should
scleroderm.
quantify the ease of performance. If you can even now, ease of performance should be added as a, and second is you should increase and complete the sample size. Any other comments? Susan? Mic, Seema, you have a
Yeah.
mic close to you.
Yes, sir. I have it now. So there was an initial earlier paper, thesis, which you had supervised, and there again you were working on internal hemorrhoids or
No, that was rectal varices. That was rectal varices, huge rectal varices in pediatric patients. So I was part of it, not internal hemorrhoids.
pediatric patients was a separate, but simultaneously there was a study in adult side also.
Yes, but rectal varices.
Rectal varus.
So there is a huge dearth of data on internal hemorrhoids.
It's there. That's what I want to know.
I'm sorry, I've forgotten offhand, but the literature reports anywhere from 10% to 80% prevalence of rectal varices, this wide variation. And honestly, on flexible endoscopy, it is so difficult to say this is a dilated blue vein versus this is a rectal varix. Everybody has his own ideas. Ditto for internal hemorrhoids. So we have to be very careful in our inclusion, hence the limited sample size. This was a very rigid criteria of inclusion. And I'm sorry, Ashok has gone, but then I again reiterate, if a patient of cirrhosis is bleeding from internal hemorrhoids, we should be treating these internal hemorrhoids. I don't think there is any reason not to. And the question is how to, and that is what we were trying to answer.
So, I just have a small comment on about the feasibility. I think that feasibility is also a very important, responsibility which lies not only with the supervisor, also with the supervisor and the department. If the student doesn't know the feasibility as much as we should know, and so once this thesis is taken up, the feasibility part should be ours.
So our sample size was 61. We did not know how many of the patients would have internal hemorrhoids, but then the main reason is that it takes 6 months. So if a student has 1 year for his dissertation, it takes 6 months for him to go through all the regulatory ethics, BOS, this, and finally get it to register and finally to study. So more than half the time of the student is taken just to get it going. And by the time it starts, well, we had practically 6 months to do the thing. So the sample size was calculated, but I think 2/3 of the time went into the BOS, Board of Studies, ethics, that discussion in the department. So we have to streamline that.
I think we are trying to streamline that, Vikram. And
Sir.
This year, I think probably we did it little earlier. But definitely the department should, within 3 months of student joining, start giving them, and department as such would think about that. Just one small question. In your table of randomization, you said 20 failure to randomize. What was the reason for that? Well, that was almost same number as you randomized.
Sir, actually, our patient were randomized when we were doing endoscopies, and if we just to be judged if the bleeding was found to be due to internal hemorrhoids. So at that time, if I am not present or someone,
So you were not there, so you could
I was
randomize
not.
20. So that's also a limitation.
The patient was randomized on table with the scope inside him. So after diagnosing that the internal hemorrhoid is the source of bleeding, then the patient was allocated a random number.
I mean, that's what, so you have.
That's the rigor of the study. So we can't randomize.
Allocation concealed with the
Show
allocation
that table now where you're showing 20 failures.
Have it arranged.
no, ma'am, it is
You have it there.
No. So if a patient has come to you with red bleeding per rectum, we do not know he's bleeding from fissure, ulcers, or whatever.
I'm not
So-
saying that.
So once we have the patient on table, we can't call him back again for a separate procedure. We have to treat him on the spot. So the patients were randomized after I, as an operator, said, go ahead, it is internal hemorrhoid. Then the patient was randomized.
No, I only one issue here. If you are not present there, then it's that this issue is definitely right that he cannot be randomized. But if he's present and if even if
No, in these cases, he was not present. So,
Ma'am, it's
so if he-
Yeah, that's right. He was not present. That's the.
can't be there in all cases.
Anyhow, let's go to the next.
thank you.
So just one more question.
Say, mechanistically, I believe the foam should far better than liquid because it has a modulus and its spread and distribution would be far better than liquid. So in this study, if in case it didn't was not statistically significant only because of the numbers. Otherwise, it should have been far better.
So we may be well looking at a type 2 error. The logic of foam was that once you have these micro bubbles, the sclerosant stays inside, continues to touch the endothelium and has a prolonged contact and more damage. So this is what we see with the varicose veins treatment. They have all moved to foam sclerotherapy for varicose veins. So this was the original idea translated from the treatment of varicose veins. But this is what we found.
Thank you, Vikram, and thank you, Shajit.
Good morning to all of you. This is my second thesis presentation. Safety and efficacy of continuous infusion of terlipressin with norepinephrine versus norepinephrine alone in improving outcomes of acute kidney injury in patients of acute on chronic liver failure with septic shock. It is a RCT. So this is the outline of my presentation. So this is the outline of the study. So first of all, we will go with the pathophysiology of AKI in ACLF. In patients of ACLF, there is gut dysbiosis and leaky gut is there that causes increase in PAMPs and DAMP release. That causes the systemic inflammation and cytokine storms that lead to hemodynamic changes and causing vasodilatation and renal vasoconstriction, leading to kidney injury phenotypes that include the prerenal HRS, AKI, colemic nephropathy, AIN, and mixed type of phenotypes are there. And structural injury, which is more injurious, more harmful, that includes the tubular, globular, and podocytes injury. These are all the phenotypes of acute kidney injury in patients of ACLF. So there are also AKI in ACLFs include the sepsis-associated and sepsis-induced AKI. Sepsis-associated AKI, it is defined as the occurrence of AKI within 7 days of sepsis onset. And sepsis-induced AKI, that includes the injury that primarily develops as the indirect consequences of sepsis or sepsis-related therapies. Until now, there is no separate guidelines for the patients of sepsis-associated AKI in cirrhosis or ACLF. And in this patient, there is increased inflammation, creatinine and urine output behave unreliably. And sepsis-induced AKI frequently overlaps with the HRS AKI, and there is profound vasodilation that causes the reduced effective arterial volume, and faster AKI progression occurs in these types of patients that causes need of requirement of RRT in these types of patients. Till now, these are the various studies which has been done, which compared the terlipressin and norepinephrine, and all the studies have shown their better results of terlipressin in comparison to the norepinephrine. But there are challenges in using the terlipressin, like the more adverse events were there in the patients in which terlipressin were used. That causes the challenges in these studies. So newer trials are needed that include the septic shocks, that and the studies which decreases the adverse events in patients of ACLF AKI. So we hypothesized that the combining the low dose continuous infusion of terlipressin with norepinephrine, that will be the more effective in patients with ACLF and septic shock than norepinephrine alone, by causing the rapid restoration of the circulatory dysfunction and decreasing the systemic and spastic vasodilatation that leads to the improvement in renal perfusion and microcirculation, and that leads to the improved outcome of AKI in ACLF patients. So our aim of the study was to study the safety and efficacy of low-dose continuous infusion of terlipressin with norepinephrine compared to the norepinephrine alone in improving the outcomes of AKI occurring in the context of septic shock in patients with acute and chronic liver failure. Primary objective was to study the efficacy of continuous infusion of terlipressin combined with norepinephrine compared to norepinephrine alone in improving outcome of AKI in patients with ACLF and septic shock. And secondary objective was to study the spectrum of AKI with ACLF, improvement in septic shock in both groups, to compare the outcomes of AKI in both groups and need of renal replacement therapies in both groups of patients. Compare the duration of hospital stay, need of mechanical ventilation and ICU stay in these patients. Compare the 7-day and 28-day mortality between the two groups. Impact of lactate levels, systemic vascular resistance, cardiac function, renal resistive index, incidence of adverse events requiring the discontinuation of the terlipressin. So, primary endpoint was the proportion of patient developing one-stage improvement in AKI stage with resolution of shock at day 4 in both groups. And secondary endpoints was the outcome of AKI in form of resolution, persistent or progressions at day 4 and day 7, incidence of adverse events in both groups, need of RRT at day 7, duration of ICU and hospital stay of both group of patients, and 7 and 28-day mortalities. So these were the definitions we have used. First of all, the ACLF definition, which was according to the APASL, it was according to the APASL. SOC was defined as the inability to maintain the mean arterial pressure 65 mmHg despite the adequate fluid resuscitation by crystalloids of around 30 ml per kg and have elevated blood lactate levels more than or equal to 2 millimole per liter. And sepsis was defined as the SOFA score more than 2 in a patient with a suspected infection. Severe septic shock defined as the septic shock requiring NORAD requirement of more than 1 microgram per kg per minute or more at presentation or after fluid resuscitation to maintain MAP more than 65. And reversal of shock will be defined as the maintenance of MAP more than 65 after discontinuation of all vasopressors. And these are the definitions of AKI. And progression of AKI is progression to higher stage or need of RRT, and regression is decrease in the KDIGO stage to 1 stage lower, and partial response is regression of AKI stage with serum creatinine reduction to more than 0.53 milligram per DL, but it was above the baseline, and full response is return of serum creatinine to a value within 0.3 milligram per deciliter of the baseline value. And this was the inclusion criteria. First of all, we had included the ACLF, AKI according to KDIGO criteria, and septic shock requiring norepinephrine less than 0.05 microgram per kg per minute. And these were the exclusion criteria. Septic shock patient requiring more than 2 vasopressors, norepinephrine requirement more than 0.05 microgram per kg per minute, and cardiopulmonary disease, patients having cardiopulmonary disease, CKD, peripheral vascular disease, HCC outside Milan. Prior use of terlipressin in last 48 hours, patient with hypovolemic or hemorrhagic shock, A patient already meeting the criteria for dialysis or with history of dialysis in last 7 days. Intrinsic kidney disease, history of immunosuppressive drugs, pregnancy, immunodeficiency virus, and PBT. So this was the methodology. Patient at the time of admission, we take the complete history. Patient having recent, we have to ask for recent diuretic use. Patient having recurrent vomiting, loose stools, signs of fever, sepsis, recent contrast use within 7 days, or any nephrotoxic drugs, prior renal dysfunction, CKD, history of hemodialysis, hypertension, diabetes, renal stone history, and severity of liver disease at the time of admission was taken. So initially, within 3 hours, we have, before the randomization, we have to withdraw any nephrotoxic drugs. We have hydrated the patient with 5% albumin according to the first protocol. Urine output monitoring was done every hourly map, and pulse rate was recorded. Broad spectrum IV antibiotics started within the first hour of admission in patients of suspected or proven sepsis was there. Lung ultrasound and IVC collapsibility. IVC was taken every hour for 3 hours. Fluid boluses were given according to the IVC collapsibility. And if the IVC collapsibility is less than 40% or ultrasound shows the B lines, we have stop the fluids. And patients who improved after giving fluid boluses and after IV hydration within the 3 hours, they were excluded from the study. So after that, the patients were randomized in the 2 groups. In the first group, patients in the terlipressin group, patients were started with low-dose terlipressin infusion in addition to the norepinephrine. At the day 1 milligram continuous infusion was started, which if the patient doesn't respond, it was increased to 2 milligrams on the second day, then 3 milligram, and then 4 milligram on the 4th day. And in the second group, norepinephrine was started at the low dose at the 0.05 microgram per kg per minute to maintain the MAP of 65. So in both the patients, continuous monitoring was done in form of MAP, urine output, heart rate, metabolic parameters like lactate, blood sugar, electrolytes, and daily chest X-ray, PCT was done accordingly. So this is the considered diagram for our protocol. So sample size was calculated. It was come according to the, 126 total, 63 in the each group. It was taken from the studies which have done in 2022. According to that, till AKI in the septic shock in ACLF, the response was 15%, and it was further assumed that the response rate increases by 20% in the experimental group. So the new response rate was 35%. According to this, the sample size was calculated. So what was the criteria for stopping our study? So patients who required the third vasopressors, patients who required the norepinephrine dose of 0.5 microgram per minute. So in that study, the study was stopped and it was taken in the salvage group. The patients having the IVC more than 25 mm, collapsibility index was less than 40%. And patients having B profile on the ultrasound, they were also excluded. And severe side effects of the drugs like C grade 4 comes, they were also, we have to stop the study in this kind of patients. And the patients who were further taken LAMA, unwilling for the further hospital stay, they were also, in that scenario, we also stopped the studies. So this is the results. Total 430 patients where patients were assessed for the eligibility. In them, 304 patients were excluded, And the total excluded patient include the septic shock requiring the 2 vasopressors. They were 220. CKD patients were 15 prior use of terlipressin last 48 hours. It was 15 patients who were having hypovolemic shock. They were 47, and they responded to the IV fluids. And the patients.
Doctor, I must say that you've really been successful in ensuring that we don't get to see anything. What are we seeing here? I mean, I do not know. Can everybody see? I can't see anything.
Yeah, what color is it? Any of
This was the baseline characteristics. All the parameters were comparable in both the groups. So the primary endpoint was the day 4 shock reversal and stage 1 AKI improvement was there. It was significantly better was in the NORAD terlipressin group. In shock reversal was 59 out of the 63. Stage 1 AKI shock reversal at day 4 was in 59 in out of total 63 patients. And in norepinephrine group, it was 33 out of 63 patients. And in context to AKI improvement by stage 1, it was 47 out of 63 patients in NORAD terlipressin group. And in norepinephrine group, it was 28 patients who were secondary outcomes was length of the hospital stay. It was around 13 in the norepinephrine group, and norepinephrine terlipressin group, it was around 11 days total hospital stay. RRT requirement was 7 in 7 patients out of 63 patients in norepinephrine group, and in norepinephrine terlipressin group, it was 9 patients who required the RRT requirement at day 7. And the AKI outcome at day 7 was in the resolution of AKI, it was 45 patients who have resolution of AKI at day 7 in NORAD terlipressin group.
You can also say percentage, for 70%, 44%. So say that because more informative.
Persistence of AKI was in 15%, and progression of AKI was 12% patients shows in NORAD terlipressin group. And in norepinephrine group, resolution of AKI was seen in 44%, persistence was seen in 38%, the progression was.
For which this thing variable is this p-value, or is it a complete p-value?
Complete p-value.
Is it for resolution of AKI?
No, AKI outcome total of complete 3.
All the 3. They've taken out all the 3.
This is a secondary outcome, day 7.
I agree, but one p-value for all the 3, or is it for resolution of AKI?
No, because AKI outcomes will be either resolution, persistence, or so AKI outcome p-value.
And mortality was comparable in both groups. 7-day mortality was 12%, and 28-day mortality was 28% in NORAD terlipressin group. And in norepinephrine group, 8% and 12% 7-day and 28-day mortality respectively. So these were the adverse events seen in the patients of NORAD terlipressin group. In terlipressin group, diarrhea more than 4 times per day in 6.3% patient.
No, just don't stand there and read up every digit written there. Just tell us what is the interpretation of this slide.
In terlipressin group, adverse events were more common in comparison to norepinephrine group. Diarrhea was more common. It was around 6.3. It was the commonest one, and followed by hypertension and bradycardia was also seen in 2 patients. These were the hemodynamic and renal parameters changes which were seen over due course of time from day 1 to day 4, in which we have seen that there was a difference in their numerical improvement was seen in patient in MAP equivalent norepinephrine dose, urine output, and albumin requirement and IVC diameter in NORAD terlipressin group, but there was not statistically significant. But the requirement of the equivalent dose of norepinephrine requirement in NOR and terlipressin group, it was significantly different. And due course of time in the patients in which terlipressin was added, the requirement of vasopressor was significantly less in patients comparison to the norepinephrine group. So this was the trend graph which we have made. In that shows the requirement of norepinephrine was in terlipressin group, requirement of vasopressors was decreasing over the due course of the time. So these were the predictors of day 4 AKI recovery, in which absence of the in multivariate analysis, absence of grade 3 ascites, if EGFR was higher at baseline, and in the treatment in the terlipressin group it was 3 times, and absence of grade 3 ascites, that is 9 times, has better predicting the AKI recovery at day 4. Strongest was the absence of grade 3 ascites now. Second to in the arm group, in the patients in which terlipressin was added, that has shown the better AKI improvement at day 4. So what were the predictors of 28 days mortalities? In univariate analysis, age, ARC score, baseline lactate, baseline MAP, and the early AKI recovery have shown that they have better 28 days, less 28 days mortality was seen. And in univariate analysis, only the ARC score and baseline lactate was significant. So in patients, in this study, we have also seen the patients who has early AKI recovery, means AKI stage 1 improvement at day 4, have shown that the patients have 0% mortality at day 28. So patients who have recovered AKI at day 4 by stage 1, they have better survival, and there was no mortality was seen at day 28. So to conclude this study, we have seen the combining NORAD with terlipressin significantly improved the day 4 shock reversal and early AKI recovery compared to the norepinephrine alone. Early AKI recovery strongly predicted the lower 28-day mortality. Secondary outcomes, length of hospital stay, RRT requirement, short-term mortality were similar, though AKI resolution favored the combination therapy. Higher baseline EGFR, diuretic use, absence of grade 3 ascites, and combination therapy independently predicted the AKI recovery, and continuous terlipressin infusion was safe and well tolerated in the patients of ACLF AKI.
Yeah, comment from moderator guide.
I think so. This is a much needed study because we see terlipressin has problems with adverse events, but if you combine at a low dose, it has all the benefits, avoiding the adverse events and causes rapid reversal of the circulatory dysfunction. So that was the main purpose why we designed the study. And there were so many things which had to be done as a part of this, but he has not been able to get time to do all that. So we have to do a lot of things here to look at the role of bile acids, because we see that these patients have bile acids causing circulatory dysfunction. But they may, like the stage recovery, we just said 1 stage recovery. So most of these patients with shock did not get a complete recovery by day 4. So even 1 stage recovery and improvement in hemodynamics was making a difference in the overall outcomes of these patients. So these were the 2 things. So this can be a very good translational study where we can also look at the challenges and the inflammation. So where he has not done is sepsis associated where the clear cut the patient had sepsis, but many a times we see in ACLF, it is just sterile inflammation causing. So those two sets of patients should also be compared to see whether terlipressin works better in that set of patients. So that, and I invite comments from the audience.
My comment is only to the student. This is a very good study. It appears that some work has been done. But Dr. Sab, you need to go back and make proper slides so things can register in my mind. Did you show your slides to Raki?
So just to make, I'm not discouraging you, but you have not addressed even my single suggestion given to you, and you've just presented the same set of slides.
Can I just say a few things? Interesting one, actually. I'm not sure, but I'll go reverse way. So can we start with your conclusion slide? I'm just going to go reverse. So what you're trying to do in this conclusion is basically there was no impact on morbidity and mortality, right? There was nothing on morbidity and mortality in terms of both the group. But on your second line, you're trying to put in early AKI strongly predicted lower 28-day mortality. This is not what you set out to look into, because this is giving a wrong information about the trial. This trial didn't produce an impact on mortality. There was no impact on mortality. So I don't agree with the second interpretation which is being done from your data. That's not the right interpretation of the data. Okay. So because when you go to your fourth conclusion, because there are lots of things which are affecting your early recovery of AKI rather than the combination of terlipressin and noradrenaline. There are many other factors which are impacting.
So can I just...
Let me just finish out on this. So I don't agree with this conclusion being made from this trial. Now, when we go back on this, your own department has actually published quite a few things.
Can I just interrupt? Because see,
No,
it's very clearly written early AKI recovery. We have never said terlipressin is causing 28-day mortality. We are saying early AKI recovery predicted mortality. What combination is doing is just causing AKI recovery. That is the conclusion.
So that is what you're trying to do, that you're trying to put 1 + 1 together, which is not right here.
Is causing anyway. We've not
That's a wrong interpretation of
No, we've not written anywhere. I think so. You're reading it wrongly. Early AKI recovery predicted lower mortality. There is nowhere written terlipressin is reducing mortality.
Okay. Now coming to, this has been done before in CLDs in the same department, right? NORAD plus terli versus NORAD. And then meta-analysis has shown NORAD is good, right? NORAD is good enough. You don't need combination of terlipressin. That data is there, I think, in the literature. So what is the mechanism why you think terlipressin is making impact here? And then coming back to, because one of the most important problem with terlipressin is side effects of gut translocation, which leads to increased side effects, which is what you're shown. But you're not come in your conclusion that you're shown safe, right? But your slide on side effects, you're not drawn those in complete bracket. Go on side effects.
I think we have paucity of time. I will show that table quickly. The side effects were shown. Pamit's side effects were shown, and he has mentioned about those.
Yeah. But
and what is he trying to say?
What he has done is he's just taken it individually, not the complete package of side effects. Terli versus NORAD. Because that is the most important thing which has been in the literature about terlipressin, that it has got lots of adverse events. And this has to come as a complete package, and then you do the whole calculation here and show whether the p-value is significant or not. If you take individual, there will always be, you won't get enough numbers. This is a 63 patient, isn't it? You won't get enough numbers for adverse events here. Because this is the main problem with terlipressin. It is not safe.
All right, your point is well taken. I mean, he can reanalyze those things. Any other comments from anyone?
So, sir, missed the entire hypothesis. This is the entire hypothesis behind doing this study.
Anyhow, thank you, everyone. And there is an announcement. Harsh, please make it.
I'd like to invite everyone tomorrow for the AI summit from 8:30 onwards. The DST secretary is also coming. This is a startup open house artificial intelligence based conference for the whole day. So I invite all faculties and students to be there through the day and attend this program. Thank you.